Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. This episode features content from an educational symposium titled Accelerating the Pace Toward the End of the HIV Epidemic. During this podcast, Dr. Chloe Orkin, Professor of HIV at Queen Mary, University of London, and consultant physician and lead for HIV research at Barts Health NHS Trust at the Royal London Hospital in London, United Kingdom, discusses strategies for successful treatment initiation in people newly diagnosed with HIV. To follow along with the accompanying slide set, please visit the link in the show notes for this episode. Now, let's get started and hear what Dr. Orkin has to say about rapid ART initiation.
So in terms of recommendations for rapid treatment, the good news is that you are in line with international guidelines. And if we look at the granular detail of what the guidelines say, the DHHS say to initiate immediately or as soon as possible. IAS USA say start as soon as possible, including immediately after diagnosis if ready. The EACTS guidelines, it's clearly a more nuanced analysis of this, whether rapid, possibly same-day treatment is proposed. It depends on the setting, on the circumstances, on the medical indications, and the risk of loss from care. And for the WHO, rapid initiation should be offered to all people following a confirmed diagnosis and clinical assessment. So there's generalized agreement, but guidelines are very clearly saying, assess the situation, assess the person in front of you, and make a nuanced decision. So what we do know is that there are clear recommendations of what first-line therapy should entail, and we can see that these are predominantly based on second-generation integrase inhibitors. In almost all cases, we can see that the sole exception to this is the EACTS guidelines that also includes the use of Duraviron. And you can see that two-drug therapy with dolutegravir 3TC is in the DHHS, IAS USA, and EACTS guidelines. So if we think about the rapid ART treatment studies, so what I've done is I've collated the rapid antiretroviral studies onto a single page. So what we have are three trials. We have the FAST study, looking at bictegravir, FTC, and TAF. We have the STAT study, looking at dolutegravir 3TC. And we have the DIAMOND study, looking at darunavir, cobicistat, FTC, and TAF. So in terms of study design, they're all very similar. They're single-arm studies. The DIAMOND study was first, and then all the other studies followed suit. And they're basically prospective single-arm studies, multi-site, and they are for people who are newly diagnosed with an infection generally within the past 2 weeks and no previous treatment. And you can see that the aim is to initiate treatment with the first dose within 24 hours of the baseline visit and before we have lab results available. And the primary endpoint is either an undetectable viral load at 48 weeks or at 24 weeks. So you can see that these studies are really, really similarly designed, and we're always told not to cross-compare studies. So what I'm doing here is showing you the similarities in the study design. So in terms of the baseline information, what we can see is that the studies were also similar in that they recruited very young people, the median age ranging between 28 in the DIAMOND study to 36 in the FAST study. They were almost exclusively men who entered these trials. The log viral load was around 4.5 log. And you can see that high proportions of people had high viral loads in excess of 100,000 copies. And there were actually people who had viral loads in excess of 500,000 copies. Now, that shouldn't be surprising to you because we're talking about newly diagnosed people. But what is different is this is not the population that we see in the first-line therapy studies nowadays. Okay, we tend to see about between 15 and 20% maximum of viral loads greater than 100,000 copies in normal first-line therapy studies. So it's a slightly higher viral load population. And the median time from diagnosis to enrollment was between 5 and 8 days, and low rates of hepatitis B, as we tend to see in generally in many of these trial populations. So if we start with the bictegravir, FTC, and TAF, the FAST study, what we see is that week 24, which is the primary endpoint, 80% of people undetectable on the ITT FDA snapshot. And you can see that regardless of viral load, the results were excellent. But there were differences in the rate of suppression depending on the viral load. There was no resistance at through week 24, and there was low rates of safety adverse events. Moving to the STAT study, which is looking at two-drug therapy with dolutegravir 3TC, Here we're looking at a week 48 primary endpoint, and what we are seeing, certainly in the observed analyses, are 97% of people suppressing. But when we look at the intention to treat or the FDA snapshot, there are lower rates. There were no treatment emergent resistant mutations, so none at all. And the safety record was there was no grade 3 to 5 drug-related events. What we did see is similar outcomes regardless of viral load, less than or greater than 100,000 copies. But what we saw in this study is that there were people who had to switch away from 2-drug therapy in instances where it's not indicated. So we see people moving away who had baseline M184Vs, people who were pregnant, and reasons like that. So good outcomes here too. And then in the Diamond study, which was the original study looking at immediate therapy, and we're looking at darunavir here, what we see here is very similar outcomes, again by intent to treat, around 84% of people with viral loads less than 50, no one meeting the criteria for resistance testing, and low rates of safety endpoints, good outcomes above and below 100,000 copies. So on the face of it, in terms of the trials, everything's looking very, very similar in terms of the outcomes. Now, in terms of transmitted primary integrase and darunavir resistance, how important is resistance, transmitted primary resistance? Well, what we know from the first-line therapy trials, it's very unusual in first-line therapy for a second-generation integrase inhibitor to select for resistance in first-line therapy. And consequently, the DHHS guidelines recommend integrase inhibitor resistance testing only if transmitted resistance to integrase inhibitors is a specific concern or if there's viremia. And the IAS USA guidelines advise similarly not to do it. But interestingly, the DHHS guidelines also recommend darunavir for rapid start due to low risk of resistance, even with intermittent adherence. So I think that there are concerns about not starting treatment in the advent of potential resistance. So in terms of integrase inhibitor baseline resistance substitutions, if we look at the data in 1489 and 1490, which was the bictegravir FTC and TAF and dolutegravir FTC and TAF studies, what we saw is that pre-existing integrase inhibitor resistance was present in 1.3% of people in both studies. And this was predominantly the T97A mutation, which is a common mutation, and that all patients actually achieved undetectable viral loads despite this. So actually, it didn't actually affect the outcomes to have this mutation. So I guess summing all of that up, because it's a bit confusing, what we're saying is these regimens are unlikely to generate the resistance. We have very little data on people in the studies who had this type of resistance, but for those that did, there were no concerns. The guidelines, the DHHS and the IAS USA don't recommend that we do the resistance testing prior to starting, but they have recommended a PI-based combination for immediate treatment. So, Babafemi, let me ask you, firstly, do you use same-day initiation?
I would like to, but logistically this is a challenge in my practice. So I talk about it, but in reality, I don't always follow through, just because of the logistics of getting the drug, doing the counseling, etc. But it's certainly offered. And
if you did do it, what would you prescribe? Or give me several options, or just one option?
It will depend on a number of things, like what's available, the patient's insurance and things like that. But it will be a combination of one of the second-generation integrase inhibitors, so bictegravir or dolutegravir, combined with two NRTIs.
Two NRTIs. Okay, fine. What about you, Kumar?
Of course, we had the similar observation that how to implement this same-day ART after seeing our own data, and as well as from other lower and middle income countries. If we lose them, they may not come back to care. So we do extra efforts on doing counseling them and make sure that try to initiate, not on everybody, on some people who can accept and we know that they'll adhere to ART on the same day. And coming to the drug regimen, we have limited options in India. So again, we have the regimen to initiate is TLD, tenofovir, lamivudine, and dolutegravir, as a fixed dose combination to initiate. Of course, we also have TAF, FTC, and bictegravir as a FTC available, but in a small proportion of the patient who don't have TB or a pregnancy, we do that, but primarily on TLD combination.
Thank you for that. Linda-Gail, I'm just going to ask you to tell me, do you do it?
We try to. WHO recommends to us that we offer it to all, but give people the option to opt out if that isn't what they want to do. And I think that's sensible too, that people do what they want to do.
And do people take it up?
I think they do, yeah. And we, again, encourage, because it's amazing. You can lose people, in the 50 meters of walking from one room to another room. It's particularly in my setting of antenatal care, that's really critical that we offer it ASAP.
Well, thank you for those reflections. That was really interesting. So I think another population where we really don't want to lose people, and it's very easy to lose people, is adolescents. And I draw your attention to this study of bictegravir FTC and TAF in people over the age of 15, and we're looking forward to a readout on this study. So this is a systematic review of initiation within 14 days of eligibility across 4 randomized clinical trials compared with standard of care. And what this literature review shows is that same-day treatment increased the likelihood of initiation in the first 90 days, retention, and virological suppression at 12 months. So you can see here some benefits, and these are the sorts of benefits that Linda-Gail is alluding to. So a few years ago, it's actually quite a long time ago now, it's 2017, I remember listening at CROI to this study being presented, and it was the RAPID study in San Francisco looking at rapid initiation, and they were doing it in order to try and stop losing people exactly between one room and the next. And what they found is that you could really see a big difference in terms of faster virological suppression in these people who started rapidly compared to historical controls. And what I found interesting about this cohort is that I remember that many of the people involved were people of color, and actually many of the people involved were experiencing homelessness, and many people were using substances. So it was actually a very difficult to access group of people, and yet they had these stunning results, because I think there were a lot of skeptics and people thinking, oh, that's all very well with some people, but actually they managed to access people that would normally find it hard to engage with care. The exact opposite of this cohort, which I'm about to show you, which is the Dean Street cohort in London. And they were a cohort of people, which is a predominantly MSM cohort, who either initiated within 2 days of diagnosis or historically. And once again, what you saw for this cohort, I won't stress the baseline characteristics, but basically you saw shorter time to first medical appointment, shorter time to initiation, and high uptake of treatment at the first medical appointment. So I guess the points that are being made about not losing people between the time they have the test and the time they leave the next room, you can really see that there's evidence regardless of setting. And we're hearing that from Linda-Gail. We're seeing that from the San Francisco cohort in a population that would find it hard to take treatment. We're seeing it in the Dean Street London cohort. So I guess we did some work in my research center, the Share Collaborative, looking at acceptability of offering rapid antiretroviral therapy to people living with HIV in East London to understand the acceptability. And we asked about barriers and facilitators and the needs of people regarding adherence and engagement in care. And as far as we know, this is the first qualitative study exploring the acceptability of rapid antiretrovirals in the UK. And our cohort is a very diverse cohort. But we managed to enroll, interestingly, a predominantly male sample of newly diagnosed people with HIV. And our findings really showed that having a tailored approach and working on sort of a quality relationship with the clinical team and the need to provide comprehensive information and peer support in navigating the service was very important. But what we found is that we needed to try and look at strategies to recruit a more gender diverse sample, and people who didn't accept rapid antiretrovirals or stopped rapid treatment, because actually many of the women didn't actually accept rapid treatment. So that was something that we found. So I'm going to give voice to Yvette again.
My advice would be start as soon as possible. I had to start when my CD4 count was 200, and I fought for South Africans to get ARVs as soon as possible, not to wait. When 200, it's like your body has wasted already. Repairing your immune system, it was difficult at the time. You would get sick from the ARVs, you'd get sick from just being sick. So start as soon as possible. There's no need for you to wait.
Fine. So take-home points are that as per the international guidelines, rapid initiation should be offered to everybody after a diagnosis is confirmed and clinical assessment has occurred. because it helps engagement with care, improving time to first appointment, time to virological suppression, and is associated with patient satisfaction.
Thank you very much to Dr. Orkin and our panelists, and thank you to our listeners for joining in. As a reminder, to view the slide set for this podcast and the full Accelerating the Pace Toward the End of the HIV Epidemic program on the Clinical Care Options website, click on the links in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.